Good evening, and welcome to Colon Cancer Awareness and the Black Community, Information, Screening, Prevention, and Hope. Tonight's program is being brought to you in partnership with the RWJBarnabas Health and Rutgers Cancer Institute of New Jersey. My name is Dale Colston, and I'm the Principal Librarian at the James Brown African American Room of the Newark Public Library in Newark, New Jersey. On behalf of our Director, Jocelyn Bowling-Dixon, and Board of Trustees President, Dr. Lauren Wells, we thank you all for joining us this evening. My colleague, fellow J-Bar Librarian Reggie Blending, and IT Supervisor Diego Quintero are providing technical assistance. We'll ask you to place your questions in the chat, and we hope to address those later on in the program. I would like to acknowledge the traditional, ancestral, and unceded territory of the Lenni Lenape First Nations on which we are learning, laboring, and organizing today. We also recognize the devastation and the continued legacy of the transatlantic slave trade, which contributed to present-day systemic racism and oppression. On August 28th, actor Chadwick Boseman passed away from complications related to colon cancer. Boseman, who brought the movie Black Panther to life with his charismatic intensity and regal performance, was diagnosed with colon cancer 4 years ago, but had not made the information public. His death at the age of 43 was a crushing blow to us all. And that illustration is a wonderful work by the artist Nicholas Smith. This evening, we will hear from RWJBarnabas Health surgeon Dr. Kevin Clarke and colon cancer survivor and activist Robert Patterson as they discuss colorectal cancer symptoms, diagnosis, treatment, and survival. Robert, a husband, father, grandfather of 6, and former Marine, thank you for your service, was first diagnosed with colon cancer in 2016. After several surgeries and a colorful journey, Mr. Patterson claimed health in 2018. Over the years, he's enthusiastically shared his story in hopes of encouraging others, and we will hear from him throughout the program. My colleague and friend, Michelle Jansen, is a community outreach coordinator at Rutgers Cancer Institute of New Jersey. She has a Master of Science degree in nutrition and provides community education of nutrition for colorectal health and eating for cancer prevention. Michelle, thank you so much for your patience, support, and commitment to this program. Please join me in welcoming Michelle Jansen.
Thank you so much, Dale. It is truly a pleasure, a blessing, and an honor to be here tonight. And a very special thank you to you as well as the entire team at the Newark Public Library and the IT support team, as we couldn't have done this without all of your assistance and support. And we would also like to send a special thank you to Evelyn Fuertes from the Rutgers Cancer Institute of New Jersey that also helped to put this program into motion tonight. So I am so excited to present to you Dr. Kevin Clarke. He is a Director of Surgical Oncology at Newark Beth Israel Medical Center. He was committed to a career in medicine from a very, very early age, and he's a graduate of Binghamton University and the University of Connecticut School of Medicine. He completed his general surgery medicine training at the University of Medicine and Dentistry of New Jersey, where he was also chosen to be Administrative Chief Resident. He completed his fellowship in surgical oncology at City of Hope National Cancer Center in 2006 and was subsequently recruited to the faculty here at the New Jersey Medical School. Without further ado, we welcome Dr. Clarke to our program today.
Good evening, and thank you for having me. Michelle, do you want me to start my presentation, or is Mr. Patterson going to talk first?
And Dr. Clarke, yeah, we'd love to have you start your presentation. Okay. And Robert Patterson, he'll kind of jump in, and then we'll do some dialogue.
Okay, perfect. So good evening once again, and thank you for inviting me. We're going to talk today about colon cancer screening. Hopefully there's not too much scientific detail. I try to put a combination of what I thought would be important and limit the amount of graphs and studies so that it's at least interesting and easily followable. So what we're going to talk about today is basically understanding what colorectal cancer is and what risk factors contribute to it. Specifically, how do these individual risk factors affect you as far as your risk for developing colon cancer, and then talk about some of the resources available to help with screening and diagnosis. So the colon itself is an organ in the abdomen, as you can see from this picture. It's about 5 feet long, 5 to 6 feet, and basically functions in the resorption of fluid. It also bulks up the stool and facilitates waste exchange or waste excretion. This is a picture of what it looks like. This is the inside of the colon here. You can see the mucosal folds. I know it's a little bit graphic, but this is an actual picture of a total colectomy specimen. Here you can see the beginning part of the large intestine, which is called the cecum. This is the ascending colon. This is the transverse colon, the descending colon, the sigmoid. And in this picture, we don't see the end, which is the rectum. This is not a cancer patient. This is actually a patient who had a condition called diverticulosis that required a resection. But just for anatomic purposes, this is what it looks like.
And Dr. Clarke, we're actually not able to see. We just see your beginning slide for colorectal cancer screening.
Oh, that's, I wonder why. Let's see.
And you can always try resharing too.
Let me reshare. Let's see, I think it's coming up again.
Perfect. And I think we have the anatomy of the colon here and the structure of the colon.
Okay. Can you see this one now?
And we can see everything, yep.
Okay, perfect. So this is a real picture of a total colectomy. As mentioned in that, this one wasn't done for cancer. This is a patient who had a diverticular bleed. But there are some cases actually where we actually do this particular operation for colon cancer patients. But this is just a real-life view of the different anatomic areas of the colon. So colon cancer, basically, this is the development of colon cancer. It starts, here you can see the normal mucosa, and as things go awry, the different aspects that affect the mucosa and cause it to proliferate. Uncontrolled proliferation will lead to an adenoma, and this adenoma, again, can progress to frank carcinoma, what we call adenocarcinoma. Most colon cancers are going to develop from a polyp. Some of these polyps are easily visualized like these two here, but there are cases where they're flat and they're not as easily picked up. And that can cause some of the problems with, and we'll talk about it later on, with potential problems with screening because you're not able to see them quite as well on screening colonoscopy. Again, this is another picture of what a polyp looks like in real life. You can see this is a right colectomy. This is the specimen opened up. This is the ileocecal valve, and this is what the polyp looks like. Again, this polyp was not a cancerous polyp. It was a precancerous polyp, but we weren't able to take it out with the colonoscope because of the location. So what are the risk factors for colon cancer? There are risk factors that we can control and risk factors that we can't control. So your family history, you don't have any control over. Whether or not you have any sort of inflammatory conditions like Crohn's disease, ulcerative colitis, type 2 diabetes is certainly associated with it, along with obesity. There are other things that we can control, so smoking and alcohol are two of the factors that we know are associated with not just colon cancer, but other cancers. So age greater than 50, we know that the older you get, there's an association risk with colon cancer. This age 50 will come back to because there's some changes that we know now with the beginning of screening as colon cancer has shifted a decade in terms of the rising incidence. A high-fat, low-fiber diet, so lots of red meat, that's not a good thing for you, and that has been associated with the development of colon cancer. As mentioned before, inflammatory bowel disease, so specifically these two entities, Crohn's disease and ulcerative colitis. FAP there are two genetic conditions that are inherited, and that results or accounts for about 6% of colon cancer. One's called FAP, which is familial adenomatous polyposis. Another one is hereditary non-polyposis colorectal cancer, or another name for this is called Lynch syndrome. I don't have an example of these two, but I'll show you just how much each of these affects the incidence, and a number of other syndromes that can affect your risk here. Okay. So if we look at just the addition of family history compared to no family history, you see there's a significant increase in the incidence of colon cancer. That's just with family history alone. If you look at if you have any of those two entities that we spoke about just recently, FAP or HNPCC, you see there's almost 100% incidence by the time you're 65 or 70. So in screening for these two entities is a little bit different. It's not going to reflect the average screening that we're going to recommend. But once we've diagnosed these families, we look at them very closely, and their prophylactic treatment or prophylactic surgeries that we perform to prevent cancer, because we know that over time it's a very high incidence of them developing cancer. So this is the breakdown of what of who gets it, or how it's generated. Most cases, as in with most cancers, are sporadic, which means it just happens from random mutations, and then the minority of the cases are going to be associated with specific genetic inherited syndromes. And this entity family history, that means you have a family history but no identifiable actual genetic mutations. So when we look at colon cancer or colorectal cancer, it's the third leading cancer that we have in terms of incidence and also death rate. If you look at across the U.S., the incidence in New Jersey, I don't know why this is flipping back. The incidence in New Jersey, you can see here, if you focus on the green, it's fairly high. The mortality here, if you look over here, although it's not as high as in other locations in the country. We'll talk about the reasons for some of that. It's about 150 cases overall. Does the screen keep going back and forth?
It does, Dr. Kevin. It seems like there's a little bit of a delay, but we're on the Figure 9 for colorectal cancer incidence and mortality by state. Okay.
So now you should see the estimated number of colorectal cancers total by age. Are you seeing that slide now? Hopefully. It's about 150,000. Okay. Go ahead, Michelle.
And we can see that slide now.
Okay, perfect. So it's about 150,000 cases per year. This is the breakdown between colon and rectum. Again, the majority of patients who are going to get colorectal cancer are going to be older. Although there's a significant portion of patients, and again, we'll come back to this point, in the younger age group that we're starting to see more colon cancer. Again, as you get older, this is the incidence of colon cancer as you get older, which you can see depicted here graphically. Now, who gets colon cancer? This is a graph showing both the incidence and the mortality in males and females. Keeps going back and forth. Majority of cases are going to be in males, you can see here, compared to females, both colon and rectum. And the mortality, for the most part, is going to be similar. This is incidence, 5-year survival, broken down by age on this part here, stage. So if you look at all stages here, the best group is the 50 to 64-year-old. Localized cancer is cancer that's stage 0, stage 1, stage 2. All groups tend to do the same in all ages, but you see the older you get, which makes sense, your survival also decreases. In addition to just cancer-related survival, there are other competing issues. Older patients tend to have other comorbid conditions that also affect their survival. Similar with regional disease, you see a drop-off as you get older, and the same thing once you have metastatic disease. This graph over here reflects race and ethnicity with the same overall stage. As you can see here, if you key in here on the light, I guess it's light green, this is the African American population, and you can see in every group here, the survival is inferior. And we'll talk about what the potential reasons for that is. The black male-female across the country, the incidence is slightly higher compared to other ethnic groups. Now, if you look specifically at New Jersey, we have the ability to not just look at the state, but sometimes to look specifically at counties. This is up and down. So this is a breakdown of the incidence based on county. This is Essex County here. The dark blue represents the higher incidence compared to the light blue. And you can see here, Essex County is one of the higher incidence areas. If you go south, the southern part of the state, it's a very high incidence. The population here tends to be a little bit older, so that may reflect a lot of this difference or discrepancy in the incidence. This is just the number of cases in Essex County. This is over a 5-year period, almost 2,000 cases in Essex County. Overall, the incidence, and this is a consistent theme across the country, incidence has been decreasing over time. And this is pretty consistent across all ethnic groups, white, black, Hispanic, and Asian. And we'll talk specifically about some of the reasons why that is. And the death rate, similar to the incidence, has also gone down over time. This is all groups taken as a whole. Again, when we specifically look at New Jersey, and I showed a similar slide earlier, again, the incidence is slightly higher in blacks compared to whites, and the male-female ratio, it's more in males compared to females. Sorry, just keep going back and forth. Now, thanks to Michelle, we have some specific data related just to Essex County compared to the rest of the state. Again, specifically in Essex, the African American incidence is much higher in Essex County compared to other parts of the state. It's similar. Other groups are also elevated except for the white population here. This is mortality. Mortality is slightly higher. Again, these numbers may or may not be statistically significant, but it's just important to see the trends. This is the percent of patients who are screened. I apologize, I don't know why this keeps doing this. So 64% of African Americans compared to in Essex, so that's a much lower number than you would want. And you can see it's more evenly distributed in other groups. BMI is one of the risk factors, as we showed before. An elevated BMI is negatively associated with colorectal risk. Here you can see it's not significantly different here in Essex versus other parts of the state. So the majority of cases occur after age 50, as you saw by that distribution. It's a third leading cause of death, cancer-related death. Average lifetime risk is about 6%. Men and women, for the most part, are equally affected, or there's a slight predominance in men. Women are more likely to have right-sided adenomas, and African Americans and Hispanics have overall lower survival rates. So how do we make the diagnosis and how do we screen? There's just a definition. If you have symptoms, if you have abdominal pain or you have blood in the stool, then you're not being screened, you're being evaluated for a potential problem. Screening implies that you're asymptomatic, that you don't have any particular symptomatology. But if you do have any of these findings, pain, rectal bleeding, weight loss, then that's somewhat of a more urgent situation that should be attended to sooner. Now, there are different ways of screening. There's screening where we look for the detection of blood and abnormalities in the stool, and then there are visualized tests where we can actually look and see if there's any abnormalities. The recommendation, and again, this is an updated recommendation, is to begin at age 45 and get screened appropriately based on the type of test that you're using. Ages 67 to 85, it's a discussion as far as the risk-benefit ratio at that point, and it's not recommended after age 85. There are different types of tests. Again, there's stool-based tests, which should be done annually, and we'll talk about what the different types of stool-based tests are. So fecal occult blood tests, the FIT test, the stool DNA antigen tests. All of those should be done on an annual basis. These are two visualization tests. Sigmoidoscopy looks up and catches the distal part of the large intestine. This should be done every 5 years if normal, and colonoscopy every 10 years if it's normal. Again, this is what the fecal occult blood test is. It looks for blood in the stool. It's 3 consecutive samples that's evaluated, and basically it's a chemical reaction to look for blood. The FIT test looks for the same thing, but uses an antibody, the hemoglobin, instead of a chemical reaction to look for blood. It's a little bit more specific. There are less false positives here because there are less things that contaminated. And then this is, you probably heard Cologuard or one of the other companies, but this basically looks for, it also looks for blood, but in addition to that, it looks for altered DNA in the stool. Again, most of these tests, there are limitations to what they can do. They pick up invasive cancer and large polyps. But if you have a small adenoma, that may not be as sensitive to pick that up. So those are the stool-based tests. The other two are going to be the visual tests. Again, the flexible Sigmoidoscopy looks up to only the distal part of the colon, and then the colonoscopy looks at the entire colon. It's a little bit, the difference between the two is that this is both, it can diagnose and look for polyps, and it also can remove polyps. And we know that part of the reduction in, or the decrease in incidence and improvement in survival is with the identification of polyps and the removal of polyps. So colonoscopy in some is really considered to be the standard screening tool. This is kind of hard to see, but it kind of breaks down all of the different tests. The only one I didn't mention here is virtual colonoscopy, which is this middle one here. It's only done at certain places. The limitations are similar to some of the other tests. You cannot remove any polyps with this. It only identifies polyps, and again, there's limitations as far as its ability to see small polyps. If we look at how we're doing as a state, so this is a graph looking at the percentages of screening in adults 50 years or older. Massachusetts is the best. As you can see, they're almost 77, 76%. And New Jersey's all the way down here. At least we're better than some other states here, but you see we still have a ways to go here. At Newark, Beth, Israel, we have a screening program. We have two navigators here. We have an outreach navigator and a patient navigator. They basically try to facilitate patients coming in and facilitate their appointments to a gastroenterologist and have encouraged them to get screening. We have an issue, or we had an issue at least, with a lot of patients coming through our emergency room with advanced disease. And it seemed like it was a combination of things. It's hard to say exactly what the reason was, but certainly making sure that patients are aware of what the age group and what the time and the interval of the different options for screening are is going to be very important. So these individuals work throughout the entire hospital trying to facilitate and educating all the patients at the different sites as far as what the most appropriate screening should be. And that's it. Any questions? Sorry about the back and forth. The slides kept going back and forth here.
Thank you, Dr. Clarke, for such a wonderful and informative presentation. This was a lot of really great information, so thank you for providing this to us. And next, we'd love to hand the mic over to Robert Patterson. And it seems like we may have lost Robert just momentarily. But yeah, this is really wonderful. And Dr. Clarke, do you see a high awareness of the Navigator program that you had mentioned, or more people utilizing that program to get their colorectal cancer screenings?
Since the inception, yes. And I think one of the things that we've noticed is it's been easier to get them to the appointment with the gastroenterologist. One of the problems we still have is the screening tests. Again, there are options for screening. You can do the stool-based tests, which the compliance is a lot higher versus the colonoscopy. The colonoscopy, I don't think anybody enjoys a colonoscopy. So the compliance with that has been a little bit more challenging, but certainly applying the stool-based test, which you can do on a yearly basis, is also acceptable. Importantly, if you have an abnormal stool-based test, reflexively you should get a colonoscopy, and you should get that colonoscopy relatively soon after that abnormal test.
Hey, I'm back.
Oh, wonderful. Thank you so much, Robert. We're so thrilled to have you today. And I know we have so many in our audience that would love to just hear your story of strength and courage and really going through such a journey with battling and ultimately beating colorectal cancer.
Yes. First of all, I want to say thank you, Michelle, and thank you, Dale, for inviting me today. I thank God for allowing me to be here today. Real quick, I want to share part of my testimony, which is very important, and I'm going to make it real quick because I can go on forever. But we'll go back to 2012. I'm a big guy. I'm 6'3", 360 pounds. I take my physicals every year. This 2012, I got my annual physical, 360 pounds. The doctor said, okay, your blood work shows you're elevated sugar, you need some medication. Your blood pressure is elevated, here's some medication. Your cholesterol is elevated, here's some medication. Take the sleep apnea test. I take the test. Results say that you stop breathing 300 times, over 300 times in 7 hours. So now you have a CPAP machine. In my mind, I wasn't ready for that at that age. I'm thinking I'm too young for this. So I do what I need to do to start losing the weight. A year and a half later, I'm working out 6 days a week, sometimes twice a day. I'm down 120 pounds. Yay me. Comes 2015. We'll skip to 2015, and we are invited to New Jersey to my niece's surprise birthday party. Shout out to my niece, Camille Colston. We go to the birthday party. I'm living in Atlanta, so my wifey and I are flying up. As we go for security, the bell rings. It keeps ringing. I go through 3 times. Sir, we're gonna have to check you again. We're gonna have to check you personally because whatever is coming up is coming up in your pelvic area, and it's showing on the screen all lit up in my pelvic area. Okay, whatever. You search me. I go on through. We go to New Jersey, do our thing in New Jersey, come back for the weekend. On the way back to Newark Airport, ding, 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 ding. Sir, we're going to have to search you. Whatever's coming up is coming up in your pelvic area. So jokingly, I said to my wife, "Ooh, babe, maybe I need to get a doctor's appointment." All right. So we'll skip to March. This was in April 2012. In March, I ran the Spartan race because being a former Marine, I saw the video. Crawling in the mud under the barbed wire. Ooh, I can do this. April, I get the doctor's appointment. I asked for he didn't recommend, but I asked for a request to have a colonoscopy. I'm 55 years old. I never had a colonoscopy. I did do the Cologuard every year as my physical, but there were no signs there. April, I get the doctor's appointment. May 1st, I have my first colonoscopy. The doctor comes back and says, "Sir, there's something in your rectum. We don't know what it is, but it's got to go." May 4th, I saw the surgeon. It was stage 3 rectal cancer. Now, I had no symptoms, no blood in the stool, no headaches, no stomach aches. Whatever the symptoms may be, I had 0 symptoms. This is why it is so important for me to share with men, especially black men, who I am finding out have a fear of finding something, which is why they don't go to the doctor. I had no symptoms, 0 symptoms at all. I was in almost the best shape of my life, not including the time I was in the Marines, the best shape of my life. And eating healthier, the whole 9, eating healthier, working out, and bang, I'm hit with stage 3 rectal cancer. I get the surgery, and the doctor says it's going to be laparoscopic surgery. 4 or 5 days, you'll be out the hospital, you'll be fine. I woke up and I had a catheter, I had 19 staples, and I had a colostomy bag. Okay, I was in hospital 29 days. Following that, it was chemo and radiation every day for 6 straight weeks. After the 6th week, they put a port in my chest, and I was given chemo every other week for 4 months. And this chemo lasted from Wednesday morning about 8 o'clock until Friday morning around 11. So I was getting about 52 hours of chemo every other week for 4 months. And the pain that I went through I don't wish on my enemy. The pain that I went through, I don't wish on my enemy. It's suicidal because, yes, I did thinking about eating one. And when I say eating one, I mean taking a bullet because I could not take the pain anymore. Praying, people praying for me, thoughts of my wife, my children, and my grandchildren is really what stopped me from pulling that trigger. But the pain is so devastating from the chemo and the radiation. And when you're a man, okay, because I know we think different than women. We're more prideful. We have bigger egos. And when you're dad and when you're husband and your grandpa and your Superman and you're all of that, and you pretty much have it all stripped from you. If we're going back to the Black Panther, I think how did he say the powers of the Black Panther have been stripped away? Well, all my powers were stripped away to the point of there was one time when I went into the bathroom and I literally fell on the floor and I fell against the door, so nobody could push the door open, and I didn't have enough strength. It took about 20 minutes for me to be able to get up and get. So at that point, I knew that literally I could do nothing for myself. And when you're a man, as I was saying, and you're stripped of your powers, if you will, not only the physical pain, but the mental pain of not being able to do anything for yourself and your family, it takes such a heavy toll. It's depressing. It's depressing. So it's for me to share with you. I mean, I know God gave me this for a reason. He allowed us to go to New Jersey because, I mean, if I think about it, if I did not go through security at both those airports, I wouldn't have asked for a physical, or nor would I have asked for a colonoscopy. Okay? So I know that I'm here to share with any and everybody at any time I can what I know and what I went through, and pray that you don't have to go through the same thing. So I guess what I'm really trying to say is please go get your physicals and your checkups, because not everything will show up. I had no symptoms, 0 symptoms. So please, if you're listening to me, if you're a man, if you're a wife, and your husband finds it hard to go to a doctor, a friend of mine told me that she told her husband she was taking him to lunch. And on the way, they stopped at the doctor's office. She said, "Oh, I forgot to tell you we're going to the doctor first and then to lunch." But whatever it takes, you know what I'm saying? Whatever it takes, please, because I promise you, you don't want to go through that pain. And real quick, this is just me talking, that I believe that marriage is very important. And I believe that the devil will try and break marriage up. And if he doesn't do it through finances, or if he doesn't do it through infidelity, then he'll do it through sickness, but whatever it takes. So please go get your physicals and your checkups.
Thank you so much, Robert, for sharing your story. Yeah, I know that we have questions for you both in the chat box, so I'll hand that over to Dale.
Well, one question before I get to those, my colleague Reggie's going to feed some of those questions to me. Dr. Clarke and Robert, how can we encourage Black men to go to the doctor on a regular basis, and they are nearing 50? How can we get them to follow through with a colonoscopy?
It's a very difficult question. I think with education and trying to do forums like this, I think encouraging them that there are things, even though you may feel healthy and you may think that there's nothing wrong with you, you are at risk of developing all of these potential different complications. So it's not just colon cancer, it's prostate cancer, it's hypertension, it's diabetes, it's other things that they need to be screened for. I think any forum where you can get a captive audience, I think you utilize that as a springboard to try to get the rest of it done. but it also has to be, if you can make it easy, easy. I think colonoscopy, again, it's not a pleasant a thing to go through, but I think at least having them do the stool tests at a minimum, and that's one way to get them in, because if that's abnormal, then now you can encourage them to get the colonoscopy.
I agree. I think for me, like as the doc said, it's a captive audience. I share with as many people as I can anytime. Again, hopefully they'll catch it. You know, if I could just touch one, I tell them that, you know, I don't know what they expect, but one thing I do tell them is it's some of the best sleep you'll ever have before you get that colonoscopy. You know, I used to say it's that Michael Jackson sleep, because they'll say you count down from 100 and get to 97, and you know you're out like, and there's no pain involved whatsoever. I think the worst thing about a colonoscopy is the day before, and you're drinking the fluids to clean your system out.
Right.
That's the worst thing about a colonoscopy. There's no pain really involved, and yeah, I mean, and I've had several, being that I've had the cancer, so I had to have them more often since. But it's just you got to convince them to go. You just got to be convinced.
Dr. Clarke, are the screening tests for cancerous polyps and non-cancerous polyps the same?
Well, the screening just picks up blood. There are two different types of stool tests. So there's one that just picks up blood, which is the fecal occult blood and the FIT test. And then there's the Cologuard that picks up abnormal or altered DNA. The sensitivity is only going to be able to pick up large polyps, which are adenomatous polyps, which bleed, and cancer. The Cologuard or the DNA tests, in addition to picking up blood, will also examine different aspects of the stool and to look at altered DNA. There's a limitation. It won't pick up small adenomatous polyps, which are the precursor to cancer over time. The ones that the hypoplastic polyps and some of the other polyps that don't tend to bleed as much won't be picked up as much.
Thank you. Robert, you mentioned that before you discovered you had rectal cancer, that you were in the best shape of your life and you were eating properly and exercise. Dr. Clarke, can you speak to the importance of diet and a good diet, or is a plant-based diet what we should aim for? Can you talk about that, please?
So I'm not sure you necessarily need to have a strict plant-based diet itself. I mean, I think a balanced diet is good. One of the things that we know, one of the strong associations is red meat and processed meat. So I think as long as you avoid those, have a balanced diet. I think also obesity and inactivity, as you saw on the charts, is also associated with an increased risk. But there's lots of different diets. I'm in no way, I'm not a nutritionist. I can't really tell you specifically what specific types. But again, things to avoid are going to be the red meat and the processed meats. And increased fiber is going to be good.
A question from one of our guests. If one has colorectal cancer, are you at higher risk for other cancers?
So it depends. So if you have colorectal cancer, it may be part of a syndrome. If it's part of the FAP or the HNPCC, which we spoke about before, then certainly you're at risk for development of other cancers. And there's specific associations with each of those different entities. By and large, colorectal cancer doesn't increase your risk of other cancers outside of having that particular mutation. But it may reflect, again, if you're overweight, if you excessively have intake of alcohol or smoking, then those are common risk factors for other cancers. So that may be one thing to look at.
Thank you. And Robert, we have several people who will thank you for sharing your story, and they appreciate your bravery in doing so. And looks like another question for Dr. Clarke. How long does it take for a polyp to become cancerous?
So traditional thought process is 10 years, and that's why the interval from a normal screening colonoscopy to the next one is 10 years. What we're finding out is that not all colorectal cancer follows the same molecular pathway. And without getting into too much detail, there are different ways that we get cancer. There are different types of polyps. Some polyps progress on that 10-year path, and then there are other polyps that progress on a much shorter and more aggressive path. This is something that's still under investigation, but I think you'll probably see in the future that the screening interval will change. And as we get more information, that certainly will change.
Thank you. Sure.
Can I just say the 10 years? And I want to say that once I lost the weight and was working out and eating healthier and the whole thing, and then I had cancer. It was once I got back, so say like around 2018. Once I felt better about myself and the whole thing, I was depressed or defeated about eating healthy and going back to the gym. Because in my mind, I worked out and was doing all of this working out and eating healthier, and bang, you still you still were diagnosed with the stage 3 rectal cancer. So why go back to the gym, and why work out, and why eat healthy if you're going to get this anyway? But I was speaking to a doctor who said, please go back to the gym, continue to work out, and continue to eat healthy, because what you had inside of you for 10 years. So why you were losing this weight, and why you began to work out, and why you were starting to eat healthy, this was inside of you. So as a result of when I did have those surgeries and everything that I went through, it was a good thing that I had lost that weight, because it helped in my entire healing process. So I just wanted to add that.
Thank you. Thank you. Robert, can you tell us how important a good support system is for your journey, or if anyone else is going through this journey?
The importance it's up here. It's off the screen, if you will. Quickly, while I was in the hospital those 29 days, I was never alone. Between my wife and my 4 children and my mother-in-law, there was someone in the room 24/7. I don't know if they worked out a schedule. I don't know what it was, but the nurses called me Fort Knox. And I mean, even beyond that, being home and the people around me and my family, again, as a man, as the pride and all that other stuff, I didn't want my sons and daughters. I lied to them, first of all, when I told them I was going to the hospital, what I was going for, because I thought I'd be out in 4 or 5 days. I didn't understand how important it was that once I was diagnosed, my children need to know so that they can go 10 years earlier than the average. But being home and like I said, not being able to do anything, my children were there 24/7, my wife, my mother-in-law. So it bothered me, again, as a man, take them away from their daily things, their wives, their husbands, their children, their school, whatever it was, to be with me. But I did have to learn that everything that you poured into your people, your family, now it's time for you to sit back and allow them to give it back to you. And that was hard to take, but it's much, much, much appreciated. And then for all the friends and the family that stood by and called and texted and came by, made me realize and understand that no matter if I know you and I know that you're going through something, I'm going to reach out to you. Whether it's we have too many ways not to. Emails, text messages, social media, phone calls, or personally. You know what I'm saying? I myself have made it a point to reach out to anyone that I know, if they're ever going through anything, just to reach out, because you need to hear. You need that. It builds your confidence.
Thank you. Thank you. Doctor, in the chat, someone is saying, hi, my daughter just had a colonoscopy today, and she's only 30. It sounds as if there may have been a medical reason for that. But should Black and brown people start having colonoscopies at an earlier age? Or I heard you mention the age of 45, and it used to be 50. Can you talk about that a bit, please?
So we're starting to see in the last few years colon cancer pop up in much younger patients. So the incidence, even though I showed over time, the incidence is decreasing across the board. We're starting to see a slight spike in that younger group, and that's why the move or the shift was to now begin at 45 instead of 50. Now, as Mr. Patterson mentioned, if you do have a family history that you're not at average risk, you're at increased risk. So that age actually shifts even lower. And it's about 5 to 10 years earlier than when the patient actually got it. It's for this particular case, if you have a symptom, it's no longer a screening colonoscopy, it's now something, it's more diagnostic. So it depends on what the symptom is and the reason for the colonoscopy. It could be related to, there are other conditions, like we spoke about before, inflammatory bowel conditions. It could be related to other causes of bleeding. So there are non-malignant or non-cancerous causes of bleeding also that you can get. So there are other reasons potentially to have the colonoscopy. And certainly at age 30, unless there is a family history, that would be a little bit early for a screening colonoscopy in a patient.
Thank you. Doctor, earlier you showed charts and there was a marked difference between Black and brown communities, and you were going to touch on that a little bit. Have you some theories or evidence or why it's much more prevalent in Black and brown communities? So
one of the main issues, I don't think there is a biological difference, meaning that if you normalize all of the factors that go into the diagnosis and screening and treatment, if you normalize all those things, it probably is not as disparate as we think or would see. A lot of it has to do with access and the ability to have access to primary care in facilities where you can get a colonoscopy. Because remember, the colonoscopy is not, it doesn't just screen for colon cancer, it actually removes polyps and prevents colon cancer. And I think that's the big distinction, is that once you've identified a polyp and you've removed it, you've now prevented colon cancer. So if you don't have access to that, the incidence is definitely going to be high, and the mortality is going to be high. So I think that's probably one of the main reasons why we have that difference. I think if things are equal in terms of access, certainly the treatment, if you have access to the same treatment, the results should be the same. There isn't a specific biologic difference that Black and brown people have versus other incidents. At least we haven't demonstrated that definitively.
Thank you. Thank you. We're coming up on our hour, and I'd like to have all panelists present some closing remarks. So, Dr. Clarke, would you like to start with some closing remarks, please, sir?
Sure. Again, thank you for having me. It's a pleasure to talk to the group. As you can see, it's very important that we have engagement and screening. This is a potentially preventable problem, and it's very important that everyone's aware of what your risk factors are, the time and the interval for screening, and the resources that are available to you. If your doctor isn't telling you to go for screening and you're 45 or older, then it's incumbent on you to tell him or her that, you should send me for screening. So we all do have some responsibility too, once we know and once we're educated.
Thank you. Robert, thank you again for sharing, and please, some closing remarks from you, sir.
Well, thank you again for having me. When you know better, you do better, okay? If you don't want to do it for yourself, that's being selfish. But if you don't want to do it for yourself, do it for your family, your loved ones. Don't be selfish. It's very important, and I just can't reiterate that enough, how important it is that you go get these physicals and get these colonoscopies. It's just do it. If you're not going to do it for yourself, do it for your family.
Thank you. And Michelle, thank you so much for presenting this with us. And I know you have some important information to share with everyone.
Oh, thank you so much. And once again, thank you so much, Dr. Clarke and Robert, for this incredibly useful and very insightful information about how we can really prevent colorectal cancer. So one of the things that we just wanted to share with everyone is we have a wonderful program here that is known as the NJC program. So I'm just going to share a really quick slide with everyone. You may have heard of NJC. This is in all 21 counties, so it's literally a resource that's in our own backyards. And NJC stands for New Jersey Cancer Education and Early Detection. So this program works with local health systems. So they work with University Hospital in Newark, Beth, Israel. They provide education and outreach as well as screening. And they provide access to free screening for breast, prostate, cervical, and colorectal cancer. And I know right now in this really tough time that we're all in the middle of the COVID-19 pandemic, so many of us have been laid off or furloughed or have lost our jobs. So if you are currently unemployed, all of these screenings are completely free. And then if you're 250% at or below the federal poverty level, all of these services are completely free, from the screening to the follow-up treatment. So you can definitely Google NJC program. It will pop up. You'll have a listing of all the different phone numbers that you can reach out to. There's coordinators in each county. So we have our program here in the Essex County area is run by University Hospital in collaboration with all of the local healthcare systems. So we thank everyone for being on the line with us today.
And again, thank you, Dr. Kevin Clarke.
Thank you.
Thank you, Robert Patterson and Michelle Jansen, for joining us this evening. This recording will be available for review in about a day or so on the Newark Public Library's YouTube and Facebook page, and we will put all supporting documents up as well. Thank you for your continued support of the Newark Public Library. Please be safe, wash your hands, wear a mask, and good night.
Good night.